Welcome back to our weekly CMR conference series. We're again joined by Dr. Greg Hundley, who's our chair of cardiology and the director of our VCU Pauley Heart Center. And just a reminder to everybody that these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided and claim your credits. And so with that, I'm going to turn it back over to Dr. Hundley. He's going to go through part 2 of his series on basics of CMR. So let me see if I can get this whiteboard up. Okay.
Well, good morning, everyone. Shannon, can you hear me okay?
Yes.
Okay, good. Well, last week, let's just make a little quick review up here at the top of the screen. We talked about voxels and pixels, and we talked about how one makes an image, right? And so if we've got a draw over here on the right side of this, if we've got a picture that has a dimension this way and a dimension this way, we talked about field of view, right? So we have kind of a length up here at the top and a width. And then to create the spatial resolution, we had to fill this picture with lines. And we called the number of lines the matrix. Right? So now let's get, if we have our lines going that way and we have our lines coming down this way, sorry, I'm crooked there. Then we have these little blocks, which are these guys. And in there are the protons. Remember? We had the little thing where outside of the magnet, the protons were spinning in random fashion, right? And then they go in the magnet, they align all their spins. Dr. Jordan talked a little bit about this too. And then we pass the FM radio wave into the target so that the protons tip their spins, right? So do that over here. And then after the FM radio wave has gone through, the protons go back, right? And they release energy, and we capture that to make the picture, and we get these pixels and voxels. And so a low spatial resolution is this box, but there are lots of protons inside, right? So it has a low spatial resolution, but it has a high signal. And over here, these little teeny voxels right here, not as many protons, so a lower signal, but a high spatial resolution. So that's what we talked about last week. So Corey, can we go back and share the screen
with the
images,
with the case on it? Yeah.
So if you are looking at the screen now, you're going to see some images. And maybe, Corey, if you can click on this image, and freeze it. Yeah. So if you look on the right side of the screen here, there's a static image, and you can imagine creating this nice picture here where we can set the spatial resolution, right? The field of view in the matrix, and we know our signal to noise, but it's only one picture. Well, in cardiovascular medicine, we've also got to be able to assess function. So Corey, can you click on this picture? So now look on the right side of the screen, and you've got a movie, right? You've got a movie. And so how do we go from making, last week we talked about, or 2 weeks ago, how we're going to make a static picture. Now we've got to make a movie, which is a whole series of pictures playing together. All right, so that's what we're going to talk about today, is how to make those movies. And that's really important in cardiovascular medicine to assess function. And then the next session that we're going to talk about is how we measure blood flow. All right, but first we got to learn how to make the movie. So let's go back to our white screen now. Okay, so in order to make the movie, and I'm going to, let's see here, change the color. So I'm going to leave all this up here at the top. Okay. And we're going to write over here our movie. All right. So our movie, just like if you're, is going to have in it frames. Right. Think about when you go to the movie theater and you look up there in the little projector box, there are frames in the movie. So you can imagine in the frames that we've got to make, the first frame might be end diastole, right? And then we're going to have a bunch of, here's our LV. It's nice and large. And then as we move through the movie and play those cine images, we get down here to end systole. So how are we going to do that? Well, what we're going to need to do is coordinate the picture taking with the EKG or some repetitive signal. So let's see, let's go to eraser. I'm going to get rid of some of this stuff up here because I need a little more space. Go back to this. Color. So at the top now, you see a QRS complex. All right. And the way this is going to work is we're going to need to make these movie frames. And so we're going to acquire pieces of information with each draw a couple things here. It's really clever how this works. You'll hear in MR, last week or 2 weeks ago, we talked about T1 and T2. You'll hear about another two paired series of terms called repetition time, or TR, and TE. And so the way we make this movie is we are going to gather information at points in time relative to this constant trigger that we see. So you see me make these little marks up above these QRS complexes. And these are triggers that in this red here, that the scanner is going to recognize. So anytime we go into the scanner, we put on these leads because we've got to coordinate our picture taking with some repetitive signal. And we're going to, in this example, use the QRS complex. Okay? And so at each point in time, we're going to take a piece of information right here, and we're going to go over here and populate one of those lines of the matrix. And then at the next interval in time, we're going to come over here and populate another line of the next frame, right? Remember our matrix? And then right here, we've got the third point in time, and we come down here and we get another line. And then look at the next heartbeat. Well, what do? Same interval, short period in time after the QRS complex. We come over here. And look at that. It just goes very nicely how you're filling up these lines filling up these frames of the movie. See how that works? So when these images are acquired, we've got to take care of motion. So one is the cardiac motion, right? So we trigger to the QRS complex. We recognize over a series of beats, we're making our movie, right? We've got to go all the way down and capture. You know, by the time we get over into here, here's our T wave. We're getting into end systole, right? And so we can capture the time frame down here. So you got a nice, clever way. It's kind of beautiful in some ways because you have implicit averaging, right? You're averaging this movie frame over a series of heartbeats, right? Everybody got that? And that's how we make the movies. So one of the key pieces of information to consider while we're doing this process is the temporal resolution, right? So over here on the right side of the screen, we need to capture frames in enough temporal resolution that we can capture end systole, right? And that temporal resolution that's very key is around 50 milliseconds, right? 40 to 50 milliseconds. So think about in the cath lab, you have, when you're taking those cine movies, you can talk about the temporal resolution in milliseconds, but a lot of times you talk about frame rate. You guys talk about frame rate in the cath lab? So you need a very high frame rate of these pictures that are being captured, and that frame rate is about 50 milliseconds, okay? So let's go back to, we were talking about up here, our voxels. Remember those guys? And we talked about spatial resolution, which we had our field of view, see our spatial resolution. We had our signal to noise. And now we've got a new factor, our temporal resolution. Okay. And these are the three things that you're going to be trading around in order to make the picture, right? So when we were talking last week about the images, remember, and we had our field of view, and then we were talking about our matrix. So I'm going to put my matrix, let's go down here. We had our field of view, and then we had our matrix. And does anybody remember the matrix sizes that we were talking about, the number of lines? We talked about that in things like 256 by 256 or 128 by 128, right? We talked about matrix sizes kind of in that range. So that means we need 128. If we pick this one right here, we need 128 of these lines, right? To make the one of the frames of the movie. So using this example up here, that means we need 128 heartbeats to make one cine movie. We have 128 matrix, spatial resolution. We've got pretty big pixels at that. So we got nice signal to noise, and we've got a very high temporal resolution because we've got 50 milliseconds, right? You need 128 lines. That's 128 heartbeats. And if the average heartbeat is 60 beats per minute, that's going to take us 2 minutes to get that picture, that cine movie accomplished. So Shelley, you're here in the room, one of our technologists. And if we want to make one of those cine movies, we were showing earlier a short axis, how long does it take us to make, just acquire the images for one of those?
About 10 seconds.
10 seconds. All right, so what's going on so that you get that cine movie? I just explained this is a relatively low spatial resolution, right? Some of the images that we acquire are at this very high, much higher, and we can even go 512 by 512. We run into trouble with signal to noise, but a lot of the pictures that you're using out there have matrix sizes 256. So how in the world did we go from 128 heartbeats taking 2 minutes at a heart rate of 60 beats per minute to 10 seconds? The answer is when you've got that really high field strength and ability to change these gradients rapidly, you can fit a lot of these lines right in here, okay? And in fact, the TR, which is really the time it takes to acquire a piece of information in what we call K-space, that can be dropped as low as 7 milliseconds. Good gosh. And what that allows you to do is group. We call it phase. Each one of those little lines is a phase encode, and we can do something called phase encoding grouping. Okay? And so that allows you to group and get several pieces of information in that window of time so that you are getting multiple lines with each heartbeat. Okay? And that's how, in about 10 heartbeats, you can fill up all of the information needed to make that cine movie. Okay? So that's a really nice way of averaging over time what's going on to create that cine movie. Does everybody get that? So in review, we've got to make a movie which has lots of frames in it. Okay. We've got to have a 50 millisecond temporal resolution. Okay. That means the amount of time between this frame and this frame is 50 milliseconds. Why? So that we can capture end diastole and end systole. See, if we have 100 milliseconds, you'd only need a few heartbeats. But what's going to happen is here's first frame of your movie in diastole, then the next frame jumps, and then all of a sudden systole goes like this, but you've missed it, right? Because your frame rate is too low. So you want to be thinking, I've got to have that 50 millisecond temporal resolution to capture end systole. And in using this method, you get intrinsic averaging over the time, which is a great thing to have. You think about the cath lab, we get one frame, piece of information with the delivery of the x-rays and then collecting it. You're kind of getting the whole frame at one time, right? Now, that's great if we have a heart rate of 60 beats per minute. But in cardiovascular medicine, and like in CT, we're trying to capture information for different reasons in different ways. But we give beta blockers and all that kind of stuff. And we do a lot of stuff to kind of get a heart rate in a range of 60 beats per minute. But in cardiovascular medicine, you're not going to have everybody show up very nice for you with a heart rate of 60 beats per minute. You're going to have people show up with 80 beats per minute, 120 beats per minute. And we still get those wonderful cine movies. So how does that work, right? So now we've got to play with some of this. And this is very important, not only for the technologists, but for you as cardiologists. Well, what do you do to make that happen? So I need a new one of these, if at all possible. So now we've got a new situation. We've got a very fast heart rate. Okay, and we're going to clock this guy at 120 beats per minute. Now we got to make our movie. Right, here's our cine movie. We still need a 50 millisecond temporal resolution. Make this 150 beats per minute. All right. So remember when we had the slow heart rate? And we were capturing in this interval of time a lot of information and coming over and flooding the frame of the movie. And we were getting 1, 2, 3, 4, 5, whatever it is, pieces of information really quickly. So what was the duration of the breath hold? And they're usually 8 to 10 milliseconds, 8 to 10 seconds, right? So when the heart rate is going quickly, what you have to do get a little bit of a break. You have to, it's kind of like algebra and quick math here. But you come over here, we got to fill up, remember the first point in time, second point in time, third point in time. You take advantage of that fast heart rate. So whereas here at the 60 beats per minute, let's do this again. here we're at 150. So whereas at 60 beats per minute, we might be capturing 6, 7, 8 of those lines. What we would do when we've got 150 beats per minute is we only capture, say, 2 pieces of information, right? We reduce, and what that's called is case-based segmentation. We cut the number of lines that are going to be on the frame of the movie. We reduce that. But we're collecting them 2 to 2.5 times faster. So what ends up happening is in the same 8 to 10 second of breath hold, you have this beautiful movie constructed. So what you've got to think about, can we go back to the images? What I want you to look at, so let's click on this image here. Notice that this image right here, it's very clear and crisp. You see the endocardial surface really well. Okay? Now click on this image here. Now look here at the endocardial surface, particularly along the inferior wall. It's blurry. It's fuzzy. Okay? Whenever you have a fuzzy image, there's one of a couple things that are incorrect. Let's go back to the last white screen. This is the key that you've got to think about to make an adjustment. When you have a blurry image, either A, remember those triggers? You want to check and make sure that the scanner is capturing the triggers. If the scanner sees this QRS trigger and this one appropriately, then you're in great shape because it can reorganize all the information that it is gathering. But if some of the triggers for different reasons fall in here or in here, that's one of the causes of blurry images. The second cause of blurry images is you don't have the case-based segmentation correct for the given heart rate, right? If you are collecting lots of lines with each heartbeat, like we have over here, that works if the heart rate is low. When the heart rate is high, we collect fewer lines, but we have the benefit that we're collecting much quicker, right? Then you'll be able to resolve that endocardial surface. Everybody get that? So when you get a blurry image, the first thing you want to check is, are you getting the triggers appropriately collected? Are they registering with the QRS complex? And then number 2, do you have the amount of lines that you're capturing per frame set correctly for the heart rate? Okay? Those are the adjustments you need to be able to make. All right. So this is nice because we can deal with slow heart rates and fast heart rates to make our movies. But does everybody show up with a regular heart rate? No. So we've got a new problem, right? So that we've got to manage. Now, what I will tell you, if we look at this method of collection, and let's go back to the other white screen with the slow heart rate. We look at this method of collection. Remember, here's our heart rate of 60 beats per minute. We have our 128 by 128 metrics, all that kind of good stuff. We have a nice regular system. So we've got our red markers up here, okay? when everything is perfectly organized, how does the scanner, if you listen to the scanner when it's running, you hear this kind of constant sound. You hear the way it goes, you hear the machine. A lot of times it used to be the technologist talk to the patient, but now a lot of that's automated. So you hear this breathe in, breathe out, breathe in, hold your breath. Or it's breathe in, breathe out, breathe in, breathe out, hold your breath. You know, because you got to account for the respiratory motion, right? So you hear all those instructions, and then after that, you hear this, it's kind of a constant sound. And so what's going on is this is all captured. The scanner, when you hear that meh sound, that is all these guys, it's just cranking along, collecting these. Okay. And then the computer at the end, then it says breathe, and it stops. And when it does that, then the computer goes back, it looks for these triggers. It looks for these guys, and then it reorganizes all these little lines that you've captured based on the triggers, so that then it can go and reconstruct those pictures. And that's called retrospective gating. Retrospective gating. Okay? That's called retrospective gating. Okay? So the vast majority of the time, every time you guys show up, remember last week we talked, or 2 weeks ago, we talked about you're creating a computer program. You're setting the field of view, you're setting the matrix, right? And you're setting the time interval that you're going to collect these guys, and you're setting whether this is going to be, well, right now it's retrospective gating. Okay? And it works. And now you know you have some parameters you've got to change. If you have a slow heart rate, you need more case-based segmentation so you can fit everything into a breath hold. And if you have a fast heart rate, you have lower case-based segmentation. And as long as you're able to capture these triggers so that the computer can reorganize all the phasing codes and make your movie, you're golden. And that's why the thing is like these beautiful images. But does everybody show up with a regular heart rate? And nope, got a new problem. Now we need a new screen. Nope. So now we get into what's the most common irregular heart rate that we experience. Esteemed cardiology fellow colleagues. AFib, right. Atrial fibrillation. Okay, so when you have patients in atrial fibrillation, do we just say we can't do it? No, we do those great. And actually the images look really pretty with a lot of variety in what the heart rate is. How do we do that? Right, well, we got to go back. We got to make our movie again. And guess what? There's no forgiveness here. You still need your 50 millisecond temporal resolution. All right. You still need your field of view. The patient hadn't changed their size, right? So we got to have the right field of view. And we still need our matrix. So what do we do? If you think about the cardiac cycle, where you have an irregular rhythm and an irregular RR interval. Look at these. These are all different. Which component of the cardiac cycle changes? Diastole. Very good. Excellent. So what we can do, what's interesting there is that this T wave is going to stay pretty constant. What happens, all these are supposed to be the same. So this interval of time, systole, stays relatively constant. What changes is the duration of diastole. So what you can do is you can switch. Here are triggers. You see these. We can simply sample end diastole and just through systole. Okay? And so what happens is you kind of set this up. All these are supposed to be the same. And we acquire the information very consistently but all those points in time are the same. And that's called prospective gating. And if you were to listen to the scanner, it sounds a little funky because the way it works is you hear the breathe in, breathe out, hold your breath out, and then it's going to sound like this. Every time it recognizes a QRS complex, all it's going to do is sample for a specific period of time. And basically what you do is you look for the shortest RR intervals and you set this image acquisition piece of where you're getting these phasing codes to just occur just past that T wave. Problem solved. So why do we not use prospective gating all the time? Takes care of the problem. Because you throw away what might be going on in diastole, and sometimes we're interested in that. Okay? So if we have a regular rhythm, and it's slow or it's fast, but it's regular, we'll go with retrospective gating. If we have an irregular rhythm that's due to atrial fibrillation, we'll switch over to prospective gating. And we're still able to use this nice case-based segmentation that allows you to get very high spatial resolution. And those really pretty pictures at a high temporal resolution with an adequate signal to noise. Okay? So if we get blurry images, we are wondering, are we seeing the triggers? That's the first thing. If you put somebody in the scanner and you can't see the triggers, then you've got to come up with a way to do that. If it's a rearrange the leads, that's fantastic. Another thing you can do if they have a regular rhythm is you can trigger off of other things. Sometimes the T wave, we trigger on the T wave. It just needs to be repetitive. Sometimes we take the little pulse oximeter signal and we trigger off of the pulse. As long as it's regular, you can have the scanner go back and reorganize with retrospective gating, you're in great shape. If it's atrial fibrillation, then we pretty much need that QRS complex because we're going to switch to prospective gating, and we've got to have a repetitive component where we always see end diastole and we appreciate end systole. Okay. Are those all the situations where we have irregular rhythm? What's another one?
Dementia complexes.
Oh, no. I need a new screen. You have 5 minutes. So someone said, we've got another irregular rhythm problem here. So here's our QRS. And now all of a sudden, compensatory, non-compensatory pauses. Oh my gosh. And we have PVCs. Now, back in the old days, when we had many more knobs to adjust on these scanners, we could separate out this trigger, from this trigger. So if you are in a situation where you can, and not only could you identify the different ones, you could get into a situation where you could say, I could use prospective gating. And if I had a certain time distance between the QRS and the PVC, I could keep that piece of information. I could keep this piece of information and use prospective. I could keep this one, but I could throw away this because the PVC occurred too close. That technology exists, but the flexibility to do it and use it correctly has probably been stripped away by, or not made available to most of the technologists and things like that. So what do we do now? So all of this so far has been based on these phasing codes, right? And capturing them and oriented their acquisition to this trigger. So another thing you can do, remember our factors that we've got to account for in this are temporal resolution. Okay, so how the time interval for capturing these, the signal to noise. Okay, how many protons are in the picture, right? And then the spatial resolution. Okay, and remember that is in our picture, how many of the lines do we need, right? So one thing we can do, what's the requirement that we need on temporal resolution? 50 milliseconds, right? So can we come up with a way that, and with our cine movie over here, remember this guy? We've been averaging, right? We get one piece of information here, 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 here. What's nice is our cine movie is collected over the 10-second breath hold, and so we get that intrinsic averaging. But another way we could do this is we could capture the entire image. Mimicking the drawing above. We could capture the entire image like this. Right? We capture all of these blocks one at a time. And that's called real-time imaging. Now, why don't we do that all the time? Because we are going to have to, in order to keep this, we are going to have to sacrifice this and this. So the issue, can we do it? Yeah. Is it going to have these brilliant, bright images and all that? Well, actually, the scanners have gotten pretty sophisticated and they don't look that bad. Okay? And that's called real-time and guess what? You don't need to hold your breath. So when you get in a jam, you've got an uncooperative patient, they're very ill, their heart is very sick, there are tons of ventricular ectopy. We switch over to real-time images. The problem with it is the spatial resolution is low. The signal to noise is low, and the temporal resolution, you can't get much lower than 50 milliseconds with it. When would we want to have a temporal resolution lower than 50 milliseconds? If we were looking at things like strain change, diastolic relaxation. When we want to get a really high fidelity measurement, we're kind of limited. We can do the basics, okay? We can give you the LV EDV, the LV ESV, the LV stroke volume, the LV EF, the LV mass, but that's about it with real-time imaging. But it does give you a solution. And it works in a non-cooperative patient, right? You don't really even need triggering. You turn the thing on, you're collecting pictures. Who cares what the triggers are, whether you can see them or not? It doesn't matter. You just kind of turn this thing on. Okay? So in 3 minutes, a review. Let's go back to the first. Let's go back to the pictures. Start with those. So for those of you that can see the left side of the screen, last week, let's click on this guy, just freeze it. We talked about what we needed to do to make a single slice, a single image 2 weeks ago. We talked about T1, we talked about T2, we talked about the protons and all that kind of thing. And we talked about spatial resolution and signal to noise, right? You've got your field of view, which is the entire space that you're going to image here. Can't see the marker, but really, yeah, the entire space that you got to cover for the size of the patient. That's the field of view. And then how many lines we're going to put in there. And that works for all the static imaging. Okay. Next, in cardiology, we've got to make a movie, right? Because we're going to look at function. And to do that, we're going to acquire information very quickly in time. Let's go now to the first white screen. So when we have a regular heart rate and we can appreciate the triggers, we can coordinate the image acquisition. Okay, we can coordinate the image acquisition, the pieces of information, and orient them relative to the QRS complex, or a constant signal. And we can use retrospective gating, and go back and do this in time, and we can make these beautiful cine movies. Not everybody shows up with a heart rate of 60 to 70 beats per minute. Now, some people show up with a heart rate of 30 beats per minute. And you've got to collect the images. So in that situation, you increase the phase encoding grouping, right? So you can fit in the breath hold, right? You're going to make lots of these guys because you've got the time to do it because the heart rate's so slow. But we also have patients that show up with very fast heart rates. And so we reduce the case-based segmentation in that situation, but that's fine. Let's go to the next slide. Because we compensate for that by acquiring information much more quickly, like with a heart rate of 100, 120, 150 beats per minute. So you're adjusting the case-based segmentation in regular heart rates. You're adjusting the case-based segmentation with a regular heart rate based on what the heart rate is. High heart rates, low case-based segmentation. Breath hold stays the same, 8 to 10 seconds. Low heart rate, high case-based segmentation, breath hold stays the same, 8 to 10 seconds. Works beautifully, but you have to make the adjustment. Remember, blurry image, it's probably that, or you're not triggering correctly. And as long as you have a regular rhythm, you can trigger on anything because you can reorganize the images. It could be the QRS complex. It could be a constant T wave. It could be a pulse. It could be anything. Retrospective gating works great. Any of those things, you still change the case-based segmentation relative to the heart rate. Next slide. Now we get into irregular heart rates. The most common one you're going to run into is atrial fibrillation. Now, sometimes atrial fibrillation is very regular, and you can use the retrospective gating, but if not, you switch over to prospective gating. And the scanner is going to sound different. It's not broken. It's going to go, mah, 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 mah. It's going to trigger on each QRS complex. It's working perfectly because the duration of systole remains constant. And the images turn out really nice. And then lastly, sometimes you're going to get into a situation where there's so much ectopy, oh my gosh, and we've got to switch to real-time gating. Why do we not use that all the time? Because it's got a lower spatial resolution, lower signal to noise, and you're really limited at the temporal resolution. But it does work. And you don't need to hold your breath. In fact, we use that in other times when we're looking at does the septum slide over from the right ventricle to the left ventricle in patients with pericardial constriction, things like that. We use that real-time sequence, okay? So that's how we capture the movies, okay? So we've talked about 2 weeks ago how we get a still picture, T1 and T2 and tissue characterization. And now you've learned how to collect the movies. And when you get a fuzzy picture, you know what you can adjust to get the picture to look adequate as to what you need. Now, next week, or 2 weeks from now, we've got to measure blood flow. And we'll talk a little bit about perfusion, okay? And then you'll have your total toolkit that you can come in, and that's what you pretty much need for being a technologist in this area in space, and also to be an image interpreter. If you know these 3 buckets of things, you're going to be able to get through 95% of what you need to do to answer the case and all that kind of good stuff. Okay? Any quick questions? All right. Well, thanks everybody. And what's next week, Corey?
I think next week we're going to be doing a case study, and we'll try to reinforce some of these concepts on building Cine clips and everything. So
Yeah.
We'll be back next week for that. Look forward to doing it. And oh yeah, so Shannon's got the CME slide up. Thanks, Shannon. Thank you, Dr. Hundley. This is great.
Yeah. All right, you guys